Thank you, Dr. Fry, and I want to thank the American College of Cardiology for the invitation for our presentation. It is my pleasure to present on behalf of my co-principal investigator, Dr. Roberto Lang from the University of Chicago, and multiple investigators from around the world. This study has been funded by the American Society of Echo Foundation, MedStar Health, and the University of Chicago with in-kind donations from Ultromics. Transthoracic echocardiography has emerged as the leading cardiac imaging modality for patients admitted with COVID-19 infection. Myocardial injury has been linked with poor outcomes. Therefore, an echocardiogram at admission may prove to be a powerful tool to predict death. The role of artificial intelligence in cardiovascular imaging, and specifically echocardiography, is expanding to facilitate image acquisition and image analysis. With reader-dependent technologies such as echo, fully automated AI-based analysis should result in lower variability of results than those obtained from human reads. And with increased interpretation consistency, it is foreseeable that the use of automated measurements could improve the capacity to predict outcomes. Therefore, our study had two aims. On the first phase, it was to explore the association of echo variables with in-hospital mortality, and on the second phase, to describe the performance of machine learning-derived algorithms for predicting death in patients admitted for acute COVID-19 infection and its incremental value to that of expert echocardiographer analysis. The WASE-COVID study was designed as an observational international study. The phase 1 was retrospective. Patients were enrolled if they were hospitalized for COVID-19 infection as checked by PCR or specific antigen testing. They also had to have a clinically indicated echocardiogram. The echo acquisition was based on protocols by each of the enrolling centers, considering that COVID could present safety hazards. So protocols from each center were accepted. The analysis of the echo, however, was central and was independent to any clinical information. It was all done based on ASE guidelines. The second phase was prospective, and this was follow-up of at least 3 months after the initial admission. This follow-up was done with through a medical encounter, by review of medical records, or by phone call of the patient, or a phone call to the family in case the patient was deceased. The outcome was all-cause mortality. Overall, 870 patients were enrolled at 13 centers in 9 different countries, as you can see in the world map here. As I mentioned before, the echocardiograms were acquired according to the standards of each of the enrolling institutions. The images were uploaded to the cloud. In the cloud, a commercially available software called EchoGo Core by Ultromics was used to produce an automated measurement of the left ventricular ejection fraction and left ventricular longitudinal strain. In addition, each echocardiogram was analyzed twice by one investigator, by the same investigator, out of a pool of 7 expert readers. Therefore, for each echocardiogram, there were 3 measurements for ejection fraction and 3 measurements for longitudinal strain. Those were averaged to address associations and prognostication. The mean age of this population was 59 years old. 44% were female, and as you can see, at the time of the echo, 46% of the patients were in the intensive care unit, 27% were on mechanical ventilation, and 18% were on hemodynamic support. The mean left ventricular ejection fraction was 60%. The left ventricular longitudinal strain was minus 18.7, and the right ventricular free wall strain was 22.8%. The in-hospital overall mortality was 21.6%. As you can see on this figure, the mortality was lower on the patients enrolled in Asia and Europe than those enrolled in Latin America and the United States. Left ventricular longitudinal strain was independently associated with in-hospital death. Left ventricular ejection fraction was not. As you can see in the two models that were run, age, left ventricular longitudinal strain, LDH, previous lung disease, and right ventricular free wall strain were all independently associated with mortality. So for the first phase of our study, the conclusion is that when measurements were averaged, left ventricular longitudinal strain, right ventricular free wall strain, in addition to age, LDH, and previous lung disease were independently associated with in-hospital mortality, while left ventricular ejection fraction was not. We then performed a separate analysis. Rather than averaging all the measurements, we separated the AI automated measurements and the manual ones. As you can see here, the association with in-hospital mortality was significant for AI, both for longitudinal strain and the ejection fraction. However, the measurements obtained through manual traditional reads were not significantly associated. Therefore, we posed the phase 2 hypothesis: left ventricular ejection fraction and left ventricular longitudinal strain obtained using AI-derived algorithms will have less inter-reader variability and will result in a better predictor of mortality than expert readers. Because variability was a key issue to address here, to the initial echo analysis, we added one more run of the artificial intelligence so we could do variability, and we added a third round of the echo expert read. I want to mention here that the round 1 and round 2 of the echo expert read were done by the same person, and the third one was done by a different person. So we could do intra-observer and inter-observer manual read. Overall, 476 echocardiograms were analyzable both by manual and AI, so they could be compared. The follow-up was a mean of 230 days. Mortality during this complete follow-up was 27.4%, including 188 deaths in the hospital and 50 deaths that happened during the follow-up. Variability for AI analysis was significantly lower than for manual. As you can see here highlighted in green, the Pearson correlation and intra-class correlation coefficients were very close to 1 for all the AI measurements on the ejection fraction. And that was true whether we consider all the echoes in which the same frame of the ultrasound was used, or those in which there were different frames being used. The manual, on the other hand, were much lower correlated with death. Similar results were found on the left ventricular longitudinal strain analysis. We looked at factors that could be responsible for that within patient variance. We looked at the frame selection, which frame of a loop or all the echocardiograms was used, which operator did the analysis, the reading round, and the image quality. As mentioned before, variation in AI measurements was very small, and it was almost exclusively due to the selection of the frame, meaning 2 different frames were used for the measurement. The variance on the manual analysis, however, was much larger, and it was mostly due to different operators performing those analyses. When we looked at the predictors of mortality in univariable logistical regression analysis, the measurements obtained through AI analysis, both for ejection fraction and longitudinal strain, were significant prognosticators of mortality in hospital and during the follow-up. However, when we looked at the manual reads, there was no power of prediction. The same results held true when we looked at the multivariable forward-step logistical regression analysis. Therefore, the AI, EF, and AI longitudinal strain were independent predictors of mortality. Our study has some limitations. Patients were enrolled in a retrospective manner. Not all echocardiograms could be quantified. Echocardiograms did not include sufficient information to assess the left atrium, diastolic function, pulmonary pressures, or some other variables. Findings may be applicable to patients with COVID-19, but not necessarily to other patients. However, if broadened to a wider patient population with better image quality, it is conceivable that AI contouring could be feasible in a much higher proportion of patients and therefore have more power. In conclusion, automated quantification of left ventricular ejection fraction and left ventricular longitudinal strain using artificial intelligence, minimized variability. AI-based LV analysis, but not manual, were significant predictors of in-hospital and follow-up mortality. AI analysis of echoes could increase statistical power to predict outcomes, possibly requiring smaller sample sizes in clinical trials. I want to finish by thanking the multiple investigators from around the world that made this study possible. I want to thank you for listening to my presentation, and I open to comments and discussion.
Dr. Asch, thank you very much. This paper will be discussed by Dr. Judy Hung. Dr. Hung?
Thank you. I want to thank you, Dr. Asch, and your co-investigators for presenting this innovative research. This type of research where you're harnessing the power of data sets from multiple centers into a registry and then applying machine learning to improve diagnosis is potentially transformative. And I applaud you and your co-investigators for undertaking this type of multi-center collaborative work with ongoing implications for further digital integration into clinical decision-making. Can you expand on the workflow that's required for integrating the machine learning, particularly from the de-identification process to the upload to the cloud and then the analysis and then back to the sites? Did that add a significant amount of time or additional impedance of workflow?
Yes, thank you for your comment, Dr. Hung. The de-identification specifically was performed because of HIPAA compliance and other regulatory compliance. It was performed at the centers before images were uploaded to the cloud. So each center was provided with a very small, simple software, and they would run the echo through this software so images get de-identified. By the time they get uploaded on the cloud, they are already assigned a study ID. The flow itself of the AI analysis is actually quite simple. It's almost completely automated. The only factor that the human has an input on during that process is on accepting or rejecting the frame in which the image is to be measured. Other than that, everything is performed completely automatically from a machine standpoint. Of course, this is a concept that applies to this specific software we use. There are other softwares that may operate in different manners. And the analysis itself is almost automatic, to be honest. And it's commercially available. It's something that actually is being used for other purposes in clinical practice. So that is the process.
What's the turnaround time? I mean, is it a minute, 2 minutes, another 10 minutes into the study before you get your results? Just, do you have a sense?
Yeah, well, that will depend on the context in which you're using it. If you're using it in a clinical setting, it's not something I can answer from the research perspective. It's short, it's a few minutes, because it only requires that acceptance or rejection. Obviously, from a research perspective, we did not have the urgency of turning results within a few minutes, but it can be done if that is the case.
And an additional question I had was if you could give us a sense of how feasible, in terms of the number of studies, how feasible was the AI able to do analysis compared to the manual? And you mentioned 470, but is that out of the 870 that you started with?
That's actually a very, very important question. The feasibility of analysis was very similar for and machine. It's not that the machine was able to measure EF more frequently than what humans could do. Now, what is important to understand is because these echoes were all acquired in the setting of the initial months of the pandemic, time was of the matter. No one wanted to be exposed more time than was needed, and the image quality on these echoes was definitely lower than what we are used to in regular clinical trials. And that is why there was a lot of drop-off.
I see. That was why I went from 800 to about 476.
Exactly.
Okay.
Exactly. Yes.
And all right, that's fine. I think we're actually getting out of time. So Federico, I want to congratulate you and your co-investigators for this novel research and look forward to seeing much more in the future.
Thank you. Thank you very much.
So welcome to today's panel session, where we'll be spending some time discussing our research, our recent research with some collaborators and partners on COVID and the use of echocardiography, working with MedStar and the University of Chicago. This research has produced some significant findings, we believe, that are both in press and in submission relating to the use of echocardiography in COVID, and also the use of artificial intelligence in the analysis of echocardiograms in the COVID scenario. I will be joined by our primary investigators from these partner institutes, being Dr. Federico Asch from MedStar Health and Dr. Roberto Lang from the University of Chicago. So I wonder, Dr. Asch and Dr. Lang, can you tell us a little bit about what WASE-COVID is and how this trial and project came about?
Yes, of course. Thank you, Gary, for inviting us here and for partnering with us for all this last year in this project. I will start by mentioning what WASE is. WASE is a program, if you want, a research program that Roberto and I started several years ago with the initial project that was called the WASE Normal Value Studies. The concept of that was trying to get together investigators from around the world to collaborate in answering questions that could not easily be answered by a single institution or a single investigator. In order to do this, we brought ideas to the American Society of Echo on the development of this program, and with high enthusiasm from the society, we actually started working on the partners from what is called the International Alliance Partners from the American Society of Echo, which is basically multiple societies of echo or related to echo from around the world. And we reached out to them and we said, listen, this is the project we want to do. Would you like to be interested or would you like to be part of it? And as a result of that, with the initial study, we actually had a huge success, a lot of interest from our partners around the world, a lot of interest from our colleagues, even here in the US, and a fantastic result of science coming out of it. Not only science, but also partnership with industry, with different pieces within industry to be able to develop this program. At the time that COVID pandemic started, we were done with that project. We were in the process of writing multiple manuscripts, but the data collection was already done, which really triggered some discussions among two of us. Roberto and I were very interested on replicating the model that we use for the WASE normal value studies to try to understand better what was happening to the hearts of people acute COVID infection. So we quickly gathered several investigators from around the world, again, a concept similar to the previous study, but now with the aim of enrolling patients at their countries, in their own institutions, that were admitted to the hospital with positive COVID-19 and who had echocardiograms to try to do a quick analysis on their left ventricles, right ventricles, and so. So that's how the WASE-COVID study got started. It really started early in the pandemic. I would say our conversation started probably in March, April of 2020. And by end of May, June, we already had the project approved in multiple organizations by their ethics committee, and we were ready to roll. Roberto, I don't know if you want to add any more to this description.
No, I think it's a very good description. I think we were really interested in partnering with somebody because we had this idea. COVID was just beginning, and we convened all of these groups that we could garnish a really large number of patients. But how were we going to get these patients de-identified get to a certain place and analyze quickly to obtain information. So this is a little bit what I think motivated Federico and myself to start looking for an industry partner to get this project rolling.
At the same time as you guys, I'm sure, were seeing this COVID pandemic roll out, and like all academics, all scientists really wanting to step up and help the scenario, I can see that from your point of view, you know, you already had a consortium who work well together, is international, and so you already had some good groundwork there to leverage into some rapid research and potentially useful information with regards to the heart, and of course echocardiography being an important part of the assessment of that. I think at the same time in Ultromics, we also had the same thing in mind, right? And we were very aware that we have, you know, not only do we have a piece of software that can rapidly analyze echocardiograms and provide perhaps some more advanced measurements like global longitudinal strain that most people, particularly in the more rural parts of the world, wouldn't have access to. But we also had, because we provide this as a cloud-based service, we also had the ability to move DICOM files around, possibly very quickly. So I think from our point of view, we were really keen to try and help the scenario using our technology in this sense. So we all became acutely aware that, you know, this COVID pandemic was a unique situation, and there was a very high mortality rate, right, in these patients. And because of that and the time periods involved, we knew that we had to work quickly in order to see whether there's anything we can associate with the outcomes. What finally made you decide to go with EchoGo as a service to help support your research here? And I wonder, you know, once you'd made that decision, obviously, whether there's anything you found of particular advantage in using our system that you might not otherwise have been able to, as far as you know.
There were a couple of things in our mind that were key. We wanted to have a centralized echo analysis. That was very important for us. That was a key piece of WASE, of the initial WASE. Not only that the echoes would be obtained at centers around the world, but actually that they could all be analyzed at the same place. That gives, from a scientific perspective, that was key for us. At the same time, we understood that this could turn into a large number of echoes, and analyzing them centralized could take a long time. We learned that from WASE. When we did the initial WASE, it took a few years actually to analyze the few thousand cases we had, and we did not know how large this was going to be. What we did know was that the clinical urgency was very high. We knew we were starting a pandemic that we were hoping was going to last just a few months, so we had to learn quickly. And at the same time, we knew that this kind of research was going to be triggered all over the world. So even from a scientific perspective, it was very important that we could deliver our research product on a timely manner.
For me, it was very important because we wanted all these echoes to be analyzed centrally. But all of these echoes, many of them were already acquired and had the names and everything. And that became a nightmare from a IRB point of view, because in order to have them sent, they needed to be de-identified. So at least at the beginning, I saw this as a huge advantage that software existed that I can use in each of that we could use in each of these sites, that the DICOM would be de-identified and then went up to the cloud where it could be analyzed centrally. So I think that was a major thing that at least at the beginning convinced me. Then I sort of figured out that this was just a minimal amount of what Ultromics did to help us out. This was just an initial step. But at that time, I thought this is all what we need.
Going back to your question, Gary, how is it that we got to know about Ultromics? In all fairness, when we outlined the needs that we had, we actually reached out to a few different potential industry partners for this. And we tried to learn more from each of them what additional factors we could get. And we really got thrilled by the ideas. First of all, the commitment that Ultromics had to pursue an academic project like this one, the resources that Ultromics was ready to put together, the track record of Ultromics, on one hand being a partner of the American Society of Echo, but on the other hand, having a product that was already commercially available, or used on a different setting though, because I knew about Ultromics because the software could be used for analysis of stress echoes. And although I did not use it clinically before, I was aware of this capacity, and I knew that it was already commercially available. So for us, that was very important because we could use this AI cloud-based system not only to de-identify the images and move them around to the core lab, but even to do an initial run of the ejection fraction and the longitudinal strain as the images were being transferred on the web, in a manner that by the time we would get the images in the core lab, there would also be an attached report to it that was produced by this AI platform. So all these made Ultromics an ideal candidate for us. And that is really what moved us to select Ultromics as our partner.
Another thing that was interesting for me, because together with Federico, we were talking to other companies who is that I felt that, I think we both felt that Ultromics had a genuine desire to do something to help with COVID. And I think it was not just another thing, but they really wanted to be part of trying to help out, the same as all the physicians are trying to do something. And I think that was very convincing, that they really wanted to be part of it and to do it.
Yeah, I mean, thanks for saying that. I think we were very excited about the research prospect and very keen to help with the COVID scenario, but also, you know, Ultromics is a clinic, like we know, we're clinician-led and we're researcher-led, right? Most of us here are clinicians and researchers. So, you know, the conducting research and good quality research is really what excites us, and really why we built this company into what it is. And I think you've touched on some things that we are pretty proud of here at Ultromics, which is that we don't just build software, right? We like to look at this as a partnership with the people we work with from end to end. So we try to work both in the research space, clinical space. You know, what are your problems? How, you know, we have expertise to help solve your problems, and we're willing to do this. So we both provide the software, but we also provide services for moving DICOM, research services, that's, you know, statistics, all these things that I think we all know that just providing a number isn't enough. I think for us, it's all about, you know, helping move the science forward and helping move the practice of medicine forward. So the other thing that I was thinking that is of interest to me is, you know, we were excited in this research, and I think we all engaged on it. And before we go into the findings of this research, which I think were very interesting indeed, you know, the fact of the matter is that we really leveraged our AI engineering to perform this task really quickly. And I know that applying AI is something that's growing in normality in the field and generally in medicine. But, you know, I wonder what your perceptions of the use of AI was before, you know, using it with us. And I wonder what your perception now is of the idea of using AI to perform some of these measurements.
When we started to do it, just to be again very honest, I had my wonders how good that really works, okay? So I was always trying to say, well, let's measure it by humans also to make sure that the numbers make sense. And the numbers made a lot of sense. And as we'll see later, actually AI did better than the humans because AI is less variable. So I got convinced that this is definitely the way to do it. But like everything else, you have to test it. You know, I just did not believe it by the fact that even when somebody tells me it's FDA approved, that's not, for this type of thing, I want to know by myself. And I got convinced that it is much better than what I thought.
Brilliant, brilliant. I'm so glad that, you know, we're able to demonstrate to you some about the way that we've been doing this. And I think it comes down to the fact that, you know, we're all academics and clinicians that have spun out of Oxford. And so we're using AI, but we really think it's important to make sure the stuff works and that it holds water. And I think, you know, we're totally happy to have that tested, and I'm so pleased that it's holding up. Now, you know, through the use of our services and this great partnership that we had, we were able to collect all of the images from all over the world and perform this analyses. And so I wonder if you guys could just share with us briefly. I know you know you're going to have several talks at the ACC and ASE about these findings and COVID and echocardiography, but for the benefit here, I wonder if you could give us some headlines of what the key findings are from the study in your mind.
This project started as we want to learn what if you want to call it the phenotype, the cardiac phenotype of patients with acute COVID disease was. What was the prevalence of LV dysfunction, RV dysfunction, and so forth, and how could they help us on predicting outcomes, mortality, and so. That was the initial thought. So there are findings that are related to that, and really what we see there is that there's a relative minority, if you want, of patients that have low ejection fraction or low longitudinal strain or even low right ventricular strain, which we did separate from Ultromics. And I have to be fair on mentioning that that we did analysis beyond what could be done with Ultromics at that time, at least. So we looked at different aspects, and we wanted to learn how are people using echo around the world. For example, we learned that out of 13 centers that we had enrolling patients, only 3 of them were doing comprehensive echocardiograms. The average number of loops that each of these echo had was about 30, 33, or something like that. Clearly understanding the impact that COVID and the risk for infection, safety, if you want to call it, for whomever was obtaining these images, was having a huge impact on what was being done. So clearly there were very few centers that were actually pursuing comprehensive echocardiograms on these patients. It was full protection, let's be with the patient only as needed. And that turned into, on one hand, images that were of lower quality than we are used to. We have to be clear on that. But at the same time, on more limited examinations. That is one important thing. And that was, I would say, throughout. I mean, if you think about it, it's 10 centers out of 13. So that is an initial kind of thought. Then we also look, for example, on how sick patients were. How sick were patients that were ordered an echocardiogram in different countries. And it was very clear, for example, that the patients that were enrolled in Asia, which were mostly China and the Philippines and Iran, were patients that were less sick. And we learned that, first of all, because they died less, their mortality was lower, their in-hospital and their follow-up mortality, but also because they had better ejection fractions, better longitudinal strain, both on the left and on the right ventricle. So these are things that describe what the practices of echocardiography were at the time of the peak of the pandemic. And I think those are important findings from us. And we were humbled by the amount of information we were having. I mean, and just to put this on perspective, these were not 20, 30 patients. These were almost 900 patients that were enrolled. It's a lot of you know, it's a very large case series. As Roberto was mentioning, one of the challenges that we had was coping with the idea that we were going to just trust what the AI algorithms can provide. And both Roberto and I are by nature skeptical. That's what our researcher mind is about. So we wanted to make sure this was going to be tested. So in addition to the AI analysis, we had all the echocardiograms, every single one of them, run by expert readers, by board-certified echocardiographers, not once, but twice, and not twice, but even a third time. So we could test the inter and intra-observer variability of the human reads, and we ran the same echocardiograms through the AI algorithms twice, so we could also test variability. There are a couple of things here that are very important. As Roberto mentioned, the variability was much lower for AI than what it was for the traditional manual human analysis. And we have all the numbers, the correlation coefficients, the R values, and so they are consistently much better for AI than what they are for the manual reads. But we went beyond that and we tried to understand what were the factors that turned into these variability differences. And when we looked at AI, the variability was very small, and it was mostly and almost exclusively related to the fact that in run 1 and run 2 of the AI, sometimes a different frame was picked. So it was not exactly the same image, it was the same echocardiogram, but the machine could choose one image or the other. And that frame selection was almost exclusively the source of variability for AI. That said, the variability was really, really, really small. It was almost perfect. When we looked at the same things on the manual reads, there was some variability on the frame selection, but the most important by far was actually which was the operator performing it. And here it's important to mention that it was not a single person reading. There were 7 different people reading or experts reading echoes, and they were randomly assigned for each of the echoes. So each echo was read 3 times, but it was from a pool of 7 experts. So we had the capacity to also test how much impact that operator changes had on the variability. And that was the main source by far for the manual reads, really bringing up a strong message that not only AI has less variability or higher reproducibility, but that was based on the fact that the operator was almost pushed out of the equation, if you want, compared to the manual reads. So that those are very important and powerful comments. And before I go into the prognostication tool, I wanted to give some space to Roberto to see what he wanted to mention about this.
Yeah, I mean, I agree with everything you said. I would add that, if you put a little bit what Federico put together, you can see that, or you could forecast or look into the future and see that when you use echocardiography for a certain aim to see what it does to a medication or to a certain intervention, that the use of AI could actually make a trial much more effective, right? Because if AI has less variability, then you would need less echoes in order to come to a certain diagnosis or conclusion. And I think that is something very interesting that came about. And this actually makes us all very proud. Federico, Ultromics, and me, is the fact that Federico will be presenting this as a late-breaking trial at the ACC, something that usually does not happen for echo projects. So that's something that definitely makes us very proud. And of course, the use of echo led us to, so up to that point, the literature had published very small studies. This was the first big comprehensive study, and I think Federico will explain it later again, is that we could definitely find that both strain on the left side and strain on the right side, from the echocardiographic point of view, had major, is very important regarding the implication of future events or survival in COVID patients. And we could really see this in a large group of patients. This is the first time I think that this was being noted for the left side. There were some previous papers on the right side. So a lot of unbelievably interesting conclusions came from this. But the most important thing for me is how this study came together, that it shows a good example of an idea, and then the way that you can collaborate with industry to make this a real project, and to get a lot of interactions. We met, I think that's something we didn't mention, that we met weekly. And it was something I think that everybody looked forward to. So we discussed which problems we had, how we could get a solution. Everybody was promptly there, and it became a very efficient way. And I think something that everybody looked in the week to do. It was a sort of a fun hour to be together, working together.
Brilliant. No, thank you. I think I agree completely with that, and I really look forward to those weekly meetings. And I think in the end, we can all agree that, I feel very proud about producing a really good piece of research, something that tells us important things about COVID itself and how we measure that using echocardiography, which is interesting and varied internationally. And also possibly how we could identify patients that are going to do worse and things like that. But even unexpectedly off the back of that, producing a really good piece of research to demonstrate the utility of AI in the analysis of images, particularly echocardiograms, with significant potential impacts moving forward. And I look forward to exploring all of those going forward in more research with yourself and other partners, I'm sure. But I think, we've stuck a really good initial flag in the ground to what is going to become the future, really, I think, of medicine, to be honest, which is the working together with advanced analytical techniques. The term AI is somewhat of a black box, but from someone like me coming from the engineering side of it, it really just is another step in complex statistics to look at problems. And I think, we all need to move with that and use that in our practices to really improve the way that we practice the art of medicine, really.
That to me is a key message, because, as someone that has been in the leading side of echocardiography for several years now, the way that AI has been perceived in our community has been creating mixed emotions. In one hand, oh wow, look, this is very interesting, and what this can do and what this cannot do. But at the same time, there has been a lot of concerns as of if this is making our job so easy, or is going to do it, what is going to be the role in the future of the sonographer, the physician? Is this machine going to replace us? That's a fear that has been in the air. And I think it is important in a situation like this one to highlight what I have been saying all along. And I am not the only one, by the way. I will be quoting other people. AI is not here to replace what we are doing. It's here to make us better. Is here to help us be more accurate, is here to make us more efficient, but at the end of the day, the rational processing that we experts in echocardiography, in CT, in MRI, or whichever one of these techniques, that is not being replaced, and that will never be replaced. How you put A, B, and Z together, machines can help us making associations, but at the end of the day, we are the ones making the final calls. So I see AI as the future of echocardiography, as part of the future of echocardiography. And I think it is on us to be able to develop it, to become that tool, to become that we are now better, to become, or to reach that point where we could say, you know what, if you don't use AI, you will never be that good. AI is here for help us being better, not for being or not being. It's for us being better. And I really, really believe that collaborations like the one we are having in this case with Ultromics, or we are doing, as Roberto mentioned, with other companies such as Caption Health, Tomtech, or any other ones. And we are open to this. We want to move the field forward. And we have felt that Ultromics had such a huge commitment to do this, that fulfilled all our expectations and way beyond that. So we are very grateful for this opportunity. I think it does fulfill our hopes for what the future of echocardiography is. And I really feel we're building something strong here.
I would just like to, I don't know, finish or add to say, I have a slide when I give this AI talks, which I think is very good, that says something that AI is not here to replace anybody, but those echocardiographic doctors that in the future do not use AI, they are going to be left behind. You know, it's I think the opposite. So I wholeheartedly agree that with Federico, what he said, this has been an unbelievably great experience.
Great, and I agree completely on that sentiment. And I guess, you know, that wraps up quite a nice and productive discussion. I think, you know, we've covered a lot of topics, and I'd just like to close by saying, you know, thanks again for putting together such an amazing research program, and I think we were honored to be part of it.
Thanks for the collaboration.
Thanks.
Thank you so much, and for many more collaborations to come.